and we will move to the public comments. I just remind kind of what I said at the beginning is public comments. We're delighted to have you all. We just want to make sure that we have your potential conflicts of interest before, according to the ICER policy before the delivering of the comments. And I apologize. I don't want to appear rude. We have a time limit. And so if I go over the time limit, I'm going to have to interrupt it. I apologize because it always sounds like I'm being rude, but I just want to sort of give a heads up about that. The first public commenter is Dr. Rebecca Angove, Chief Science Officer of the Patient Advocate Foundation.
Thanks, Jason. I will not stand between anybody and lunch, so I will stay within my time limit. Besides what's on the screen, I don't have any other conflicts of interest to report, and I'm very excited to be here today. My PhD is in public health, so I also have an affinity for vaccines. I currently serve as the Chief Science Officer of Patient Advocate Foundation, or PAF, and the Executive Director of PAF's Patient Insight Institute. I'm speaking on behalf of my organization, which focuses on addressing access and affordability issues for patients with chronic and complex conditions. So we serve directly 200 patients across the United States every year. And over the course of that work, we learn about patients' needs, their challenges, their experience, their gaps, pain points in healthcare, barriers to treatments. So much that we learn from these patients. And it's through the Patient Insight Institute that we ensure patient-centered evidence is integrated into policy, research, healthcare transformation. And so that is the hat I am wearing today as I make these comments. But I'm also speaking to you as a patient that was diagnosed with long COVID. I've been battling this complication for over 5 years. I was scheduled to have the vaccine, and I got COVID from my daughter who was back in school. We live in the South, so, COVID disappeared in the South way before it did in other areas of the country. She brought it home from school, and I got COVID about a week before I was scheduled to get the vaccination. And I truly believe that I wouldn't be battling these long COVID complications had I had the vaccine. So it's with a very professional hat on behalf of other patients, as well as my own personal experience that I'm making these comments today. So at PAF and the Insight Institute, we've done extensive insight and evidence gathering in the areas of vaccine barriers. We have some of these publications, both in peer-reviewed publications as well as on our website. We've also done work in trust in science and trust in healthcare. And I think both of these areas are really relevant to this meeting, this topic, and this report. When I'm in these spaces, I'm usually talking about cost and physical or practical access. But this conversation around COVID-19 vaccinations, both in this report and also in the years of work that we have done in my organization, it's really different. It's more complicated and nuanced. As you've heard today already, patients are being asked to weigh these minor risks, the post-vaccination malaise, the, pain at the injection point, et cetera, and some potential large risks, at least early on, with major benefits, right? Reduction of serious complications or long COVID. But those are rarer benefits. And that challenge of weighing these risks and benefits that patients are having with limited information, limited evidence, layered on top of that is competing information that's being laced with personal opinions and political rhetoric. Patients are just in this space where they are very, very confused. Patients are also really influenced, and we know this because they report this. We've done, like I said, survey work into this. They're influenced by providers' attitudes and the accessibility of these vaccinations. So even the perception of accessibility. For example, it was widely reported that vaccines weren't available and weren't covered by insurance last flu season. And I know we had a lot of patients asking, about, can I get it? Should I get it? And so the information out there is one of the main barriers that patients are seeing to COVID vaccine getting it, but also just the kind of population level uptake. When we ask these questions, we know historically vaccination rates have been high in our population, which is patients, with complex and chronic illness. But we know recently that this uptake has declined substantially. And what we're finding is that there's confusion about the guidance. That is a significant barrier where we have a recent survey that nearly 1 in 5 respondents reported delaying or foregoing a COVID-19 vaccine because they were just unsure of current recommendations. And we had earlier findings among chronically ill and resource limited patients that found when we looked at all the barriers to COVID-19 vaccine uptake, that informational barriers were way more common than cost or transportation. We also found that individuals that had a regular source of care were especially likely to report without a regular source of care, we're especially likely to report difficulty understanding vaccine information. So we know that patients trust their doctors. They're having these conversations with their doctors. If patients can't find the information reliably on their own, they go to their provider. If they don't have a regular provider, they're really struggling with understanding what to do. And they're looking to these different sources of recommendations for help with this decision making. So really taken together, I don't want to belabor all of the points that were made previous and in previous public comments, but where we,
over
yeah.
the time limit, yes.
Oh, sorry. I made them. I don't need to summarize. Thank you, Jason.
Okay. Thank you so much. Does anyone from the group have questions or comments? Thank you. With that, we will transition to our next public commenter, which is Dr. Allison Hill from the American Pharmacists Association.
Thank you, Jason. Greetings, everyone. Thank you for the opportunity to provide input today. I'm Allison Hill, a licensed pharmacist who's administered thousands of immunizations throughout my career, and I serve as Director of Professional Affairs with the American Pharmacists Association. Known as APHA, it is the only organization advancing the entire pharmacy profession and representing pharmacists, student pharmacists, and pharmacy technicians in all practice settings. Pharmacists and pharmacy personnel play a vital role in the nation's vaccination infrastructure, providing immunizations across the lifespan and serving as one of the most accessible points of care for patients. During the most recent respiratory virus season, approximately 89% of COVID-19 vaccinations were administered in pharmacies. We appreciate ICER's commitment to reviewing the clinical effectiveness and value of COVID-19 vaccines. In today's evolving vaccine policy environment, independent assessments such as this one are increasingly important for informing patients, providers, payers, and policymakers. Objective evaluations of the scientific evidence help support informed decision-making, reinforce confidence in vaccination programs, and promote continued access to vaccines that protect individuals and communities from serious disease. I would like to focus my comments on two related issues today: health equity and the need to maintain a balance between cost-effectiveness findings and demonstrated clinical benefit. First, we appreciate the inclusion of health equity in the draft evidence report. However, we believe the analysis could be strengthened by more explicitly examining social economic barriers as independent drivers of inequitable vaccine access. The report suggests that the relationship between race and vaccination uptake is less consistent than the relationship between lower income and lower vaccination rates. This distinction matters because income, transportation challenges, limited provider availability, and reduced access to healthcare services often directly affect whether patients receive recommended vaccinations. As a pharmacist, I have seen firsthand how these barriers affect patients. In many rural, underserved, and medically underserved communities, pharmacists are among the most accessible healthcare professionals available. In some communities, they may be the only healthcare provider available for miles. As a result, discussions of health equity should extend beyond demographic characteristics alone and address the practical barriers that determine whether patients can access preventative care. For this reason, we encourage the incorporation of social economic considerations more explicitly into the report and deliberation framework, and suggest recommending revising the ethical priorities to make sure that the access to vaccination and health outcomes are included into those priority questions. Adding this language would help ensure that discussions of equity reflect the real-world barriers that continue to influence vaccination uptake and health outcomes across vulnerable populations. Second, we appreciate ICER's response to comments regarding maternal and pediatric populations and its recognition that clinical benefit and cost effectiveness are distinctive measures. We agree that a vaccine can provide meaningful health benefits even when cost effectiveness varies across populations. However, we remain concerned that interested parties may focus on cost effectiveness findings while overlooking the evidence of net health benefit, including the B+ ratings for vaccine during pregnancy and among children ages 6 to 12 months, as well as the higher COVID-19 hospitalization rates observed in the pediatric populations compared with adults 50 to 64 years. These findings highlight the importance of balancing cost effectiveness with clinical benefit. While certain populations may not be represented in economic models, maternal and pediatric populations can still experience meaningful health benefits from vaccination. Because these assessments may inform future coverage and policy decisions, we encourage continued emphasis on both cost effectiveness and net health benefit to ensure the full value of vaccination in the reflection across all populations. Ultimately, value assessments should reflect the full spectrum of patients who benefit from vaccination and avoid creating the perception that populations with demonstrated clinical benefit are somehow less important because they contribute differently to economic outcomes. APHA welcomes the continued engagement to ensure COVID-19 vaccination assessments fully reflect both clinical effectiveness and the broader public health value of vaccination. We appreciate this thoughtful consideration of all the interested parties' input and its commitment to evidence-based process. Thank you.
Thank you, and thank you both for these comments. I think that your perspectives in different ways are very important and enrich our process. So we're very grateful for your time. You made a few comments about the ICER process and the nature of the questions that we are going to consider. I just wonder if someone from ICER might want to respond. There are components of the questions that disaggregate some of the things that you're talking about, right? Effectiveness versus cost effectiveness, as well as some of the points about equity and other considerations. Does anyone from ICER have a specific response to that?
Sure, Jason. So first, I think broadly, we agree with Dr. Hill on this, that cost effectiveness and comparative effectiveness are both really important things to think about as we look at these issues. And these vaccines are broadly cost effective, which makes it easy to not spend a lot of time worrying about whether a specific group you happen to be vaccinating is more or less expensive than some threshold. And some of the groups that we thought the vaccines were most important for, it wasn't so much an issue of cost effectiveness as there seemed to be hesitation in some of the policies, for instance, third trimester pregnant women, where we thought the evidence was better than maybe some other groups did. On the equity issues, we felt that your comments were appropriate on our draft report. And the structure of the way we ask questions to this panel, as we will be doing after lunch, is to put those into the other category of those first set of questions. And so in my presentation, and when we ask you all on the CEPAC to vote later, an other group that we want you to think about is socioeconomic status and implications of that, because we thought that was pretty important. And it was raised by the APHA in their comments, and we assured them in our response to comments that we would make sure that you all heard about that. And that was part of why I focused on that in my presentation.
Thank you. Any questions or comments?
Can I just
any questions or comments?
Jason, can I just tag on?
Yes,
just for
absolutely.
a second?
Go ahead. Yep.
Can you hear me?
Yes,
Okay,
absolutely.
okay, sorry.
Yep.
And yeah, thank you both, Dr. Hill and Rebecca, for your comments. I think that Dr. Hill in particular, a lot of the concerns you raise will be highlighted during the roundtable discussion in the afternoon, because as was noted at the kind of the lead in to this meeting today, we are focused on the evidence. We're focused on what the evidence is telling us and the uncertainties around that evidence. But we recognize that health systems will have to make recommendations, and they'll have to be thinking about all kinds of things, issues with access, barriers to access, vagaries in the health system that prevent coordination of care. And so I would expect a lot of that conversation to happen this afternoon. With respect to the comment about somebody may twist a subgroup result in unfortunate ways, that is a risk we always take. It is a risk with every review and report we've ever done. And I'd say that we think the best thing we can do is to be very clear and explicit about why we're concluding what we are on the evidence, and describe our rationale for the evidence ratings that we've produced. And then people may try to twist this in unfortunate ways, but we're just trying to be very clear and explicit.
Thank you, Dan. So with that, I will transition to the lunch break.